And good afternoon, everyone, and thanks for the kind introductions. And I would like to thank the organizer for inviting me here today. I'm going to talk about the bone health in the setting of patients with HIV. And I have no disclosure to report. And this is the outline that I'm going to cover today. So first, I'm going to overview about osteoporosis and its burden and why it's important. So then we're going to talk about the epidemiology of osteoporosis and fracture in people living with HIV and all the associated factors. And finally, we are discuss about how we can prevent and manage this complication. What is osteoporosis for you guys who is not familiar with bone disease? So this is a condition where the bone strength is reduced and is prone to easily fractures. So bone strength composed of two main components. So the first one is bone mass, and the second one is bone quality, which include the bone microarchitecture, the bone turnover, and also the mineralization. And you can see from the slide, so on your left side is normal bone, and the left side is osteoporotic bone. You can see they have more holes and spaces and make the bone look thinner and disorganized and easily to break. So apart from the bone strength, falling is one of the most important factors for fractures. So it is the leading cause of the major trauma. And the data show that 95% of hip fractures in older people occur after falls. So it is very important. And in the clinical practice, what we can measure is only one aspect, which is bone mass. So we measure bone mass like a bone density by DEXA scan. And in postmenopausal women and men age over 50, we use the T-score as a criteria. And T-score is a comparison between patient bone density and the bone density of the young adult, and which is they reach the peak bone mass, which is the age of about 25 to 30, and make the comparison and express as a SD or standard deviations. And for the definition of osteoporosis, this is a T-score of less than minus 2.5. And osteopenia, the definition is the T-score between minus 1 to minus 2.5. And in the osteoporotic patients who already have fractures, we classify as established osteoporosis or severe osteoporosis. And the definition for the early onset osteoporosis, so you may see the patients like young adults. We did not use only the BMD as a criteria because the bone density is not correlate very well with fracture as in postmenopausal women. So in order to diagnosis of osteoporosis in young adult, we have to do the combination between the BMD result, which is you can use either T-score of less than minus 2.5, or you can not the C-score less than minus 2 plus the history of fracture or the history of secondary osteoporosis. And the difference between T-score and C-score is that the C-score, we do the comparison between patients' bone density with the people at the same age, same sex, and same race. And you can see here, we use the bone mineral density is capture only one aspect of bone. So in reality, so it can capture about half of the fracture risk. They did not, because they did not measure bone quality, the microarchitecture, and they cannot, the bone density did not measure the risk of falling. So that's why we have to think about this when we interpret the BMD result, that other risk factor that patient may have. This slide shows that the advanced age is a really important predictor of fractures too. So here is the study look at the effect of age and bone density on fracture risk. As you can see here, this is in the y-axis is the fracture risk and the x-axis is the age. This is the study in the older women and follow for the 5 years. You can see here that age is a predictor of fracture independent of the bone density. Let's say if the patient have T-score at minus 2.5 compared between 80 years old women and 65 years old women. So the older patient may have fracture risk more, 3 to 4 more than the younger. And once the patient get fractures, they have like we call the fracture cascade. It means that once they have fracture with untreated, half of them may have the another fractures, and the risk of future fracture increase with each new fractures. For example, if you have wrist fracture, you have 2-4 higher risk of having vertebral fractures. And if one have vertebral fracture, they have 5-4 risk of having hip fracture, for example. And this is the impact of fractures. If one get fracture, like particular hip fractures in the elderly, you can see here 1/5 of them die within a year of fractures. And 30% of them become permanent disability, and 40% unable to walk independently. And most of them, like 50%, they need some help for the daily activities. So this is why we need to be concerned about osteoporotic fracture, especially in older patients, because they can cause dysmobility, decreased quality of life, and even death. And even though the fracture is a big problem, it's still underdiagnosed and undertreated. Despite we have good screening like bone density, and we also have a good intervention like anti-osteoporosis medications. So one reason may be because it's no symptom. We normally call osteoporosis as a silent disease. So you know that you have osteoporosis when you get fractures. And let's think about when you see patient in your clinic. So you're concerned about kidney disease, you're concerned about heart disease, you're concerned about liver disease, and how many of you are concerned about osteoporosis? And the doctor normally do the screening like BMD testing when a patient get fracture already, which is too late. So from the first part, I want to point out that the fracture can be prevented if you screen for osteoporosis and give them treatment. So before we go to how we can screen and we can treat, what the modality we can give to the patient. So let's see how often people living with HIV have osteoporosis and fractures. So here is the meta-analysis from the cross-sectional study many years ago, but recently the study the result is the same. So in this meta-analysis, the mean age of the patients is around 40. Except the last study that they conduct in the postmenopausal women. As you can see here, the prevalence of low bone density is about 70%, and the prevalence of osteoporosis is about 15%. And the risk of having osteoporosis is about 4 times compared between patients with and without HIV. And what about fractures? So it's been evidence over the last 15 years that the patient with HIV have a higher risk of fracture. As you can see, this is the information over the last over 10 years that they look at the comparison of the fracture risk. And you can see on the red line in both male and female that patients living with HIV, they have higher risk of fractures. And the other characteristic of the fracture in HIV, they occur about 10 years earlier compared to the normal population, and more obvious when they're getting older. And the fracture can occur the site as a general population, like at the spine, at the hip, and at the wrist. And BMD is a good predictor for fracture in HIV too, but may underestimate the fracture risk as in general population, maybe because they did not capture some risk that specific to HIV, like co-infection or the treatment. And this is a nice study just published like 2 years ago, underline the importance of fracture in HIV. So they show that the incidence of fracture among people living with HIV was associated with about 50% greater of the risk of all-cause mortalities. So all this data underscore the need of BMD testing and early prevention. So let's move on to the potential risk factor for osteoporosis and fracture in HIV. So in HIV, you have the complex interaction between host factor, the HIV factor, and also the ART. So for the traditional risk factor, or we call like classical risk factor, is the risk factor that we see in general population. This is a major determinant of the fracture risk in patients with HIV. For the traditional risk factor here, so this is I quote from many studies. They show that some is more common in HIV. For example, low BMI, like low body weight, smoking, alcohol use, vitamin D deficiency, and also hypogonadism, and also the co-infection with hepatitis B or hepatitis C. And the one that I underline is the in the study they show that is associated with fractures. For the HIV factors, so the study showed that the HIV infections and also the systemic inflammation, it affects the osteoblasts and osteoclast functions. So it's like bone resorption exceeds bone formations. That's why they lose bone and increase the risk of fracture. And some study they show that the low CD4 count is associated with fractures. And for the ART, they have two phases. Initial phase and the patients are on stable ART. So for the ART initiation, so the study showed that they have about 2 to 6% decrease in bone density either on the lumbar spine or the total hip over the first few years, which is 1 or 2 years and more. So they happen with all the regimen, but particularly in the TDF containing ART, they lose more. And the bone lose the maximum at the spine at 6 months and the hip at around 1 year. And what with continued treatment after like 2 to 3 years, the BMD trend to stabilize, or somebody they trend that increase a little bit for the most of the regimen. But for the people who are on TDF containing regimen, the bone may still continue lose. It's not like as much as the beginning, but they have the study show that they continue losing bone. And this is one study they show that they lose bone like about 0.7% within a year, per year. And this is the comparison between patients who are on TDF regimen and other regimen, for example, the abacavir, retiquavir, or TAF. You can see the difference. You may not see because it's too small. For the non-TDF, the bone loss is about 1 to 2%. And for the TDF containing regimen, it's lost about like 4 or 5%. So this is a different. And when you do the switching from TDF containing regimen to another, the patient gain weight, gain the bone density about like 1.5 to 3%. This is a TDF switching. And this is what about the ART and fracture risk? There hasn't been many studies published about the specific ART and fractures. There's one study show that they collect the data over 10 years from the VA clinical case registry. They show that the TDF and one of the protease inhibitor is associated with fractures. This is the data what we have. And in this study, you may consider like, especially in the vulnerable patients, for example, the youth and adolescents and older people, not to, if possible, like avoid using TDF containing regimen. So for summarize for the first part, the risk of osteoporosis and fracture is higher in people living with HIV compared to the general population. And the major determinant of the bone health in this population is a classical risk factor. So viral replication and the infection also affects. And vulnerable patients that you have to pay more attention is the youth, the children, the adolescent and young adult that may not have reached that peak bone mass, which is a peak bone mass is a major indicator for the fracture risk in the future. And also the older adults that they may already have additional risk factor, or they may have the history of fracture already, or have the osteoporosis. This is you have to be more concerned. And TDF, if possible, in that particular vulnerable patients, if you can avoid, it should be better. So move to the last section about how we can improve bone health and reduce fracture risk in these patients. So first, all should be given the general preventive measure. like ensure that they get the adequate calcium intake according to their age. For example, in postmenopausal women and men age over 50, the recommended dose for the calcium is 1 to 1.2 grams per day. But they prefer from the diet first, and if they cannot get the adequate from food, you can give the supplementation. So, but for the vitamin D, the recommended dose is 800 to 1,000 IU per day, and some they may have need more doses according to the baseline vitamin D level. And the target of 25 OHD is depend on individual. Like if in the patient who have fracture already, who have the osteoporosis or at risk of fracture, you may keep as high like 30 to 50 nanogram per mil. But if for general population, the target may lower to 20. And also you need to advise for the adequate calorie and protein intakes and stop toxic habit. And also advice for the regular exercise, weight bearing, strengthening, and balance exercise in case of like easily falling. And for prevention is very important, especially in aging people. And this, I just want to mention a little bit about the treatment of vitamin D deficiency. So if you have the patients who have the baseline vitamin D is really low, like 10, 15, or less than 20, if you give the normal recommended, or the vitamin D may not get to the target, you may need a higher dose. So this is a recommendation from the Endocrine Society that you can use either vitamin D2, which is a cholecalciferol, or vitamin D3, which is a cholecalciferol. And the dose is shown in the table. So in Thailand, we have the mega dose of vitamin D2. And so one capsule is about 20,000 IU. And because this is a lot cheaper of D2 compared to D3. So I normally give the patient at the initial period, like about 2 to 3 capsules, and for the first few per week, in the first few months, and then follow 25 hydroxy vitamin D level at about 3 months. And if it is getting to the target, I may lower the dose by half and about like 1 caps per week or 1 cap every 2 weeks, for example. And you can give the vitamin D either daily, weekly, or monthly. It depends on the patient preference. It's the efficacy is equivalent. And for the monitoring, so the steady state, like 100% is about like 5 to 6 months, and you may need to follow early in case of severe vitamin D deficiency, like halfway, like 2 to 3 months, to see if they need to adjust the dose or not. And if they reach the goal, it's not necessary to do the regular monitoring because the cost of the 25 hydroxy vitamin D is a lot more than the cost of D2, which is like more than 500 times. So if they're stable, they did not suggest to do like regular monitoring. You can do only if you're not sure about the patient compliance. And this is a nice study showing that if you give the calcium and vitamin D, for this study, they give the 1 gram of the calcium plus the 4,000 IU of the vitamin D3 at the same time that they give the TDF. So just only simple calcium and vitamin D supplement, you can decrease the bone loss by about 50%. So that's all for the general preventive measures. So the next one is appropriate screening. So you can do by doing the bone density, do the vertebral fracture assessment, because like more than 50% of vertebral fracture is asymptomatic. So you need to do the screening in some patients, and also the FACS too. So here's the recommendation for doing the BMD testing. In people living with HIV, at least you can do the testing in postmenopausal women and the men age over 50. And also in young adults with this condition, like have history of fractures and hypogonadism, D deficiency, or towards on the glucocorticoid. This is also risk of the fracture that they suggest you can do the testing too. And indication for the vertebral fracture assessment, as I use the abbreviation as a VFA. So as I told you that some of them, not some, or most of them is asymptomatic. So, and people can get fracture even the BMD is not in the osteoporotic range, like more than minus 2.5, and they can still get fracture. So the screening for the vertebral fracture is necessary because they can change the fracture risk classification, and they can change like if the patient needs the pharmacologic treatment. And here is the recommendation from the ISCD, which is the International Society of Clinical Densitometry. They suggest doing the vertebral fracture assessment in people who have the osteopenia and with the advanced age, or he has a history of the significant hair loss. He have the document of undocumented prior vertebral fracture, like they tell you that they have vertebral fracture but have never do the test, the screening before, and also the glucocorticoid therapy. And you can do easily at your clinic by doing just lateral TL spine X-ray, or you can do that we call densitometric vertebral fracture assessment that can be done at the same time that you send the patient for the BMD testing. And the next one is FRAX score. I'm not sure if you're familiar with FRAX score. Have you calculated this before? Raise your hand. No? Few or less than 5. Let me explain a little bit. So FRAX score is a calculator for predicting the fracture within the next 10 years. You can just simply go to the Google and search for FRAX website, and you choose your country. Here I choose Thailand, and you fill in all the patient information here, and you press calculate, and you can get the 10-year probability of fracture, either the major osteoporotic fracture or hip fracture. And you can do this either with or without bone density. And as bone density, the FRAX may not underestimate fracture risk, because if you see the clinical risk factor here, they did not include the HIV specific risk factor, did not include the type of the ART, did not include the HIV infection, did not include the HCV, or did not include the fall risk. So as in the general population, it's underestimate the fracture risk. So FRAX should not be the first line for the screening because of this reason. But they may have we can use this in the patient with osteopenia to see if they need the pharmacologic treatment or not. And after we do all the screening, we can identify candidate for osteoporosis treatment. And this is like a general population. So in general population, we say if they have no risk, let's say very healthy and postmenopausal age over 65, or the men age over 70. Without any risk factor, you do the screening. And for the postmenopausal women and the men age over 50 with clinical risk factor, we do the testing. So we count the HIV as a secondary osteoporosis. So in this case, the indication is all the postmenopausal women and men age over 50. And this is the with or without any other risk factor. Especially here is this the indication for the pharmacologic treatment. If these population have the fractures, and if they have a bone mineral density in the osteoporotic range, and if they have the FRAX score within 10-year probability of fracture above the intervention threshold, it is country specific and different among country. So in Thailand, we set the criteria at a hip fracture above 3%. Before we give any treatment to the patients, we need to do the screening of other secondary osteoporosis, either other diseases, medications, or also Malaysia. So here is the list of the osteoporosis. This is a lot. So if you do the screening and you see, patient have osteoporosis, you can refer to your colleagues. refer to you can refer to endocrinologists or like general medicine. And some is very common, like vitamin D deficiency, PPI, like proton pump inhibitor, steroid. So if they have any condition, it needs to be treated first. And also, if the patients on the TDF, you know that they have a renal toxicity. And if you see the abnormal with the calcium, with the phosphate, let's say the hypophosphatemia, you have to think about the proximal tubular dysfunction, and the patient may have the osteomalacia. So in this case, you may need to measure the urinary fractional excretion of phosphate to see if they have the renal toxicity and cause bone problem. So, and again, if your patient is on TDF containing regimen, and if possible, if you can change, it might be better in terms of the BMD improvement. So which osteoporosis medication should be given? So in short, bisphosphonate is the first line because lots of the study, they use bisphosphonate. And the study showed that it's well tolerated and safe. And the BMD rising is the same as in general population. And there's no evidence that the people living HIV get the more complication than the general population, like atypical femoral fractures or ONJ. So it's no evidence that they have more long-term complications. So you can use these. This is the first line that I recommend. And this is the study, the SET study by Dr. Hoy and colleagues. And they do the 2 years randomized open label in adult with low bone density. And it showed that they make the comparison between the group that have the bisphosphonate plus TDF, like continue having TDF, and another group is the TDF switching off, and they do the comparison in terms of BMD changes. And this is the result. You can see the upper line is the one that they add bisphosphonate. So they gain more BMD compared to the TDF switching alone. The difference is between is around 5% for the lumbar spine and about 2% at the total hip and the femoral neck. So the conclusion was that if you give the zoledronic acid, this is IV bisphosphonate, add on TDF in case you cannot do the switching off. It is more effective than you do the switching off alone, at least in the patient who have the low bone mass. And so they have another real-world study, and they show that there is combination. If you do the combination between giving the bisphosphonate and switching off the TDF, it would be better than just the common sense. It would be better than the TDF switching alone. So for the conclusion for the medical treatment, it may be necessary to consider giving the bisphosphonate to the osteoporotic patient. Even you can switching off the TDF. After treatment with bisphosphonate, you can reassess the bone marrow density at 2 years and consider that holiday 3 to 5 years after the treatment. In case of patients who have new, if they don't have new fractures and the BMD is more than -2.5. For the other osteoporosis medications, such as denosumab and PTH, they have a very few case report and small cohort. So it might consider like an alternative treatment in case you cannot give the patient a bisphosphonate or the patient have the side effect or the bisphosphonate intolerance. So for the other, like abaloparatide or romosozumab, which is new osteoporosis agent, they have no data. So in conclusion, fracture is higher in patients and people living with HIV and associated with morbidity and mortality. So assessment is you have to do the assessment of clinical risk factor in all. And DEXA screening should be performed at least in all postmenopausal women and men age over 50. And bisphosphonate is a first-line treatment. And if you can do the switching, or if you can choose, you can select the bone-friendly ART regimens. And general preventive measures should be advised, especially for prevention for the elderly people. Thank you for your attention.
Thank you. So we do have a few minutes before the close of the session for questions. I can see one over there. Thank you.
It's okay. In the meta-analysis that you showed, the mean age for the people who had osteoporosis was 41, but your recommendation is to do the DXA, the bone densitometry, at 50. So should we?
So that is the meta-analysis for a long time ago. They have the recent publication showing that even like more than 40, they still have a risk of fractures. And the reason why we did not recommend doing the DEXA screening in a patient is less than 50, because the correlation between fractures and the bone density is not obviously like in the postmenopausal woman. And some guidelines from one of the AIDS society, they recommend using the FRAX score in patients age of 40 to 50. But in reality, if you try calculating FRAX score, it's not above the threshold that people need to do the testing. So my advice is that if you see, let's say like 40 and it's completely healthy, no low body weight, no smoking, no anything, you just can wait and see.
Or if combining the frailty scoring and probably the age, if even if they're below 50, if their frailty score, if their CFS is.
I would say that if they age like 45, let's say 45, and they have frequent falling, and they have like hepatitis C co-infection, which is you cannot treat them, this is completely cure, or they have the vitamin D deficiency and low body weight, you can send patients to do the BMD testing even they have like 45 years old.
Stefan.
I have a question. Like we often see our clients with low testosterone level, and for patients with low testosterone level with normal BMD or decreased BMD, will the intervention be different?
You see the role of testosterone replacement?
Yes.
I think we can follow the endocrine society for treating the hypogonadism. If you repeat the testosterone and it's still low, and they have a symptom associated with deficiency, you can give the testosterone. But in terms of the bone health, it's increased bone density, but this is no data for the fracture prevention.
Hi, sorry, I think this might have been on a slide, but do you have any comments about whether when you switch TDF, is it better to switch to TAF, or is it better to switch to something that's completely not tenofovir?
So according to the data, if you switch to TAF or abacavir or loticavir, it's quite similar. So you gain more bone density, about like 2 to 3%. I think which is not a lot, but it's maybe important in the vulnerable groups. Yeah. And in case if you cannot do the switching, I personally think you can continue TDF and adding the osteoporosis treatment.
So this is a sort of half-formed question, so I'm hoping you'll take it and run with it. It's been a while since I've reviewed the literature on the relationship between DEXA scores and fractures. I saw that in one of the slides at the very bottom, you had pointed out that there was not an established correlation between fractures and changes in DEXA scores in, and I forget. Do you know which slide I'm talking about?
You mean the correlation between DEXA score and fractures, right?
You had it at the you even mentioned it in the talk, and then you just you moved. It's right at the bottom of the slide. I know I'm going to cause a lot of trouble here by asking to have that thing put back up, but really what I'm asking is your thoughts on a fracture is a physiologic outcome. A DEXA score is... Keep going. Keep going.
No?
There, that was it. What, the previous slide? It's not clear whether bone loss after ART initiation associates with fracture. Sorry, so it wasn't related to DEXA score, but it's a question about really kind of, from my point of view, a fracture is an outcome. And my sense of physicians, at least in the United States where I practiced until a few years ago, is that primary care physicians often treat tests as outcomes and not as things that are correlates of outcomes. And so, at least in the US, where there's massive overtreatment and overreaction to test scores, rather than the sort of, from my point of view, a little bit of skepticism about all the tests that we do. I just kind of want to hear your thoughts about, particularly when we consider using bisphosphonates, which have their own side effects. And whether or not you feel they're overused or underused, and the value of using DEXA as the metric for bisphosphonate use.
I think we use what we have, and the bone density is the best in clinical practice to assess the fracture risk, even though it's not capture 100% of the fractures. So in the literature, they capture, so maybe some they just 20% and the 20 to 50%. And should we base on the DEXA scan and treating the osteoporosis? I think in the general population, especially in the postmenopausal women and in the men, or not in the men, in the postmenopausal women, they have several studies. They show they show the fracture risk reduction. But in HIV, even though we don't have the hard outcome, like you said, like fractures, because of the study is very, very short, like only few years, and the participant is quite small. So it's not surprise to me that they cannot demonstrate fracture risk reduction, but we can assume that they should get the same result as general population. At least the BMD increase is the same.
Thank you. Any other questions for any speaker? Probably time for one more. Okay, well, if not, we're on time now, so we'll close the session with a final thank you to all four of our speakers. Thank you.
And also thank you for our moderator. Okay.